now move on to the next segment, which is the first virtual roundtable of the day. Key opinion leaders and experts in the field of diabetes will now join across this virtual platform to share their opinions and insights. And the focus for the first virtual roundtable would be on the use of SGLT2 inhibitors. To commence the session, it's my pleasure to invite the two moderators, Dr. Abbas Raza, consultant endocrinologist and diabetologist from Pakistan, who is joining us through the virtual platform. And we also have here Dr. Samanthi, Cooray, consultant endocrinologist from Sri Lanka. Over to you, madam, and over to you, sir.
Thank you very much. So we have a very interesting roundtable now. So I have a very esteemed group of academics from the region who would be discussing the burning issues on SGLT2 inhibitors. They'll be looking at it from all angles, and some consider this as a wonder drug. Is it really a wonder drug? So all the aspects will be discussed here, and we will see what the experts feel about this drug. So I would like to introduce the speakers. First of all, we have Dr. Dina Shrestha, who is consultant endocrinologist from Norwich International Hospital and Medical College, Kathmandu, Nepal. And then we have Dr. Mohammad, Dr. Hamid Farooqi, consultant in endocrinology of the Dubai Health Authority and professor at the Dubai Medical College in UAE. Dr. Mohammad Wali Neseri, who is the associate professor of internal medicine in division of endocrinology and diabetes in Ali Abad Teaching Hospital, Afghanistan. Dr. Safdar Naqvi, who is consultant physician and endocrinologist at the Imperial College London Diabetic Center in Abu Dhabi. And Professor Shahjada Selim, who is associate professor, Department of Endocrinology in Bangladesh. So I would now hand over to Dr. Abbas Raza to lead and moderate this session. Dr. Abbas Raza, are you there?
Yes, I'm here. Thank you very much. It's an exciting morning in Pakistan. And again, I would like to welcome the key opinion leaders from across from the region. Everyone has made their name and impact in the diabetes world. So I'm so happy to be in the company of these individuals. I would request our moderator to please allow me to share the screen, if that's possible. So again, the topic that we're going to discuss today is something which is very emerging, and it's something very relevant in time and age. And I wanted to make life easy for everyone, and then again, have the expert give their opinion regarding a certain case that we're going to present. And that's the case, and here is the case that I'm going to share it with you. And again, today we're going to present a case of Mrs. Malik, who are we going to evaluate for management of diabetes and possible beneficial effect of SGLT2. Is that a wonder drug for her? And for the audience and for the rest of the people who are wondering what this girl has on her face, it's in this time of COVID, it's the mask that she's wearing. And I know that most of us are going through lockdowns and smart lockdowns and curfews. So again, she's doing what the social distancing and everything is concerned, and she's wearing a mask as well. So without further ado, let me just go over this case briefly. And this is, she's a female who's 55-year-old, has diabetes for about 10 years, has refused insulin for the past 2 years because her blood sugar has been going up. Her A1C has been ranging in about 7.5 on sulfonylureas and metformin. She does have some symptoms of polyuria, polydipsia, blurred vision. Sometimes she develops lower extremities, paresthesias, and rarely lower extremity edema. She has a family history of type 2 diabetes, hypertension, and cardiovascular disease. So she's a typical metabolic syndrome running in family kind of a picture. She's currently on metformin twice daily. She's on glimepiride, 2 milligram twice daily, lisinopril about 20 milligram in the morning, and atorvastatin 10 milligram at bedtime. here are her labs. Her A1C is 8.2, her random blood glucose is about 240, and obviously microalbuminuria is 140 as well. If you look at her cholesterol, LDL is about 90, total cholesterol is 190, LDL is 90, HDL is 45, creatinine is 1.3, and the uric acid is slightly elevated at 8.2. And her liver function tests are 1.5 above the normal limit. So again, I just wanted to open the forum as this time and ask Dr. Hamid Farooqi, what are the things that you're seeing in this clinical picture, in which I'm briefly showing the general demographics, general symptoms, as well as the A1C. Hamid, over to you. If you can just say if there's anything that an SGLT might be helping her in a longer run or in a shorter run. Over to you, Hamid.
Thank you, Abbas. I really appreciate this opportunity to be in the company of my colleagues from across the region. And thank you, Safis, for allowing us this opportunity also. So going on to your question, so in her context, I think the primary thing that I would be focusing on is her hyperglycemia. So if we look at this patient and then we think that her A1C is probably a point and a half above the target that we may set for her, considering all her other comorbidities, I think SGLT2 will be a very good option for us to use in her case. As you can see on the screen in front of you, that depending on the strength as well as the particular agent that you're looking at, you can have an A1C response of around starting off roughly 0.5 all the way to 0.8%. And that in itself, when you are looking at a single agent. And the other thing is that it would take a little bit of time for this whole effect to show. And then if you go ahead of us and think that this may not be enough, you may then decide to add another agent, which may be a DPP-4 inhibitor for all the experience that we have with that. And then you get a cumulative effect. So it is the effect from the DAPA, plus the effect that you are going to get from the DPP-4. So an SGLT2 and a DPP-4 will give you a combined effect, which will take you pretty much into the 1 to 1.5% category. And that, Abbas, if you can go to that, if we look at the other important parameter, and what I'm saying here is very simple. If we aim at good blood glucose control, what we end up doing is also increasing the weight. Now, if you look at the data in front of you, what you will see is that when you are using these medications in combination, and I'm not going to go into very much details, but if you look at what you have in front of you, you have monotherapy, dual therapy with add-on and triple therapy as well. Every time you see that the person not only is gaining in terms of a better A1C control, which we discussed in the last couple of slides, but here you are also having a negative in terms of the weight. That is, they are not gaining weight, they may help you lose weight. So not only you are going to get better blood glucose control, but you are not going to pay a price in increasing their weight in this regard. So my focus would be hyperglycemia. Thank you.
Thank you very much, Hamid. And I take a flight direct from Dubai to Nepal, beautiful country. And I saw Dina in a wonderful background as well. Dina, again, if I present the same case to you, and again, have you take a look at these scenarios and ask you, we've dealt with the hyperglycemia. Do you think there's any other thing that you might want to take a step and maybe help this person?
I my don't look so bad. It's like a LDL is of 90, but we know that this patient can be helped with that. So definitely autism is. So one thing, excuse me if I will only talk about EMPA and not about all the SGLT2s, because in Nepal we have just very limited data with EMPA, because we don't have DAPA or CANA. So our clinical use on experience in this part of the country is solely on EMPA. So with the EMPA reg, we know that it has been proved that not to urea, definitely for, and not only that, not only with patients with a renal function, not only with that, but also that patient would stop the progression of a renal disease. And the other thing is, so because of this, these new studies and these outcomes, what we know now of course, metformin also the first day can start SGLT2 in these patients, and the kidney composite outcomes, no matter whether it's EMPA canvas or the DAPA CKD, everywhere we can see that they do benefit with the lipids. Can you hear me?
The voice was breaking. I think this is the fun of the new virtual world as well. I think the connectivity is giving us some issue, but again, you're fine. So you were saying something about the lipid metabolism.
Yes. So with the lipid metabolism, we can see that yeah, that the SGLT2 is good for, and is in comparison to the placebo, LDL is decreased significantly.
So your point
And
is very.
the HDL also.
So Dina, your point is very well taken. I think what you
in comparison to the placebo, so which we know.
So if I summarize, Dina, what you're saying is that obviously you can definitely help this person, and it's not only lower down the microalbuminuria, but also the LDL component of it. And obviously, there is definitely some studies which show that there is improvement in the LDL and improvement in the HDL. And again, we see the other side of this benefit by looking at the cardiovascular factors as well. So now over to Afghanistan, our dear friend Mohammad Wali Neseri, who's a wonderful person, as well as a leading endocrinologist and diabetologist in his part of the world. And I would show the same case to him, and again ask him if he sees anything in this patient that he potentially sees the benefit of SGLT2, and maybe help this person in that regard. Over to you, Mohammad Wali.
Thank you very much, Dr. Abbas, for the nice introduction and for your nice words. Thank you very much, and thank you again for giving me the opportunity to be part of this roundtable. One of the problems which is visible in this patient is hyperuricemia. The uric acid level of this patient is almost 8.2 mg/%. And one of the effects of aiding in SGLT2 inhibitor to the treatment of this patient will be that to decrease the uric acid level of this patient. As we can see on the screen, blocking SGLT2 inhibitor causes more glucose in the lumen of the nephron, and this abundant glucose competes with the reabsorption of glucose with urate, which causes more urate to be excreted. Another mechanism by which SGLT2 inhibitor causes more urate to be excreted is the increasing exchange of uric acid, and more uric acid is excreted to the urine. Decreasing uric acid level through increased excretion of uric acid has potential cardioprotective and renoprotective properties. Potential mechanism by which uric acid might decrease the blood pressure, the potential mechanism by which SGLT2 inhibitor causes cardioprotection and renoprotection is decreasing blood pressure, decrease NADPH oxidases level, decrease production of reactive oxygen species, decreasing endoplasmic stress level, and increasing endothelial cell integrity, increased production of nitric oxide, decreasing inflammation, decreasing fibrosis, and increasing renal cell viability, and decreasing epithelial to mesenchymal cell transformation. All these mechanisms are potentiated by SGLT2 inhibitor. SGLT2 inhibitor causes decreasing in uric acid level, and decreasing uric acid level has all these potential beneficial effects on the kidney. The next point which I want to show is in a meta-analysis of 62 randomized controlled trials involving 34,941 patients, quantify the uric acid lowering effect of SGLT2 inhibitors in patients with type 2 diabetes mellitus. The extent of uric acid reduction following SGLT2 inhibition ranged from 17.4 to almost 45.8 micromole per liter, which is equivalent to 0.3 to 7.5 milligram per deciliter, indicating a drug class effect. The next, as we can see in the screen, that all SGLT2 inhibitor, all agents in this class have a favorable effect on the serum uric acid level. However, there might be a slight changes from one agent to another agents and from one dose to from one strength to another strength. But overall, SGLT2 inhibitor has a favorable effect on serum uric acid level. They are decreasing serum uric acid level, and by decreasing serum uric acid level, in conclusion, SGLT2 inhibitor are found to have reduced serum uric acid level in patients with diabetes. Given the associated clinical disorder with hyperuricemia, it is of course beneficial to lower uric acid in type 2 diabetes mellitus. And therefore, given the beneficial effects that SGLT2 inhibitor were found to have on serum uric acid reduction, this would give them an advantage over other oral hypoglycemic agent. Over to you, Dr. Abbas.
Thank you very much, Wali. I think it's very comprehensive, and this is one of the more confusing, and I think you did a very good justice to the whole topic in a short time. The hyperuricemia in the setting of background of diabetes is always confusing. Who to treat, how to treat, the medication that we use, allopurinol, febuxostat, they all have plus minus. Recently, there was a black box warning on febuxostat. And again, it's a little bit controversial in this time. So again, what you're saying, and if I understand right, that instead of adding a medication, if we start controlling the blood glucose by giving something like an SGLT, you might even get side benefits of having hyperuricemia being treated at the same time. So that takes me back to. So that takes me back to the place where Mohammad is also from, but in a different center. Dr. Safdar Naqvi is working as a consultant endocrinologist at Imperial College of London Diabetes Center in Abu Dhabi. He's one of the most renowned endocrinologists in the region. Safdar, over to you. And again, showing the same case, same scenario. We've talked nicely about the hyperglycemia part by Hamid, and then Wali talked about hyperuricemia. Do you see anything up and beyond what you could help this person apart from the things that already been discussed? Over to you, Hamid. Safdar.
Thank you. I hope you can hear. My connectivity was a little bit of a problem because we have about 400 or 500 patients in the center, and the Wi-Fi is a bit kind of overworked. So anyway, thank you so much, Abbas, and also Safis, really, for giving me this opportunity. So I thought there were two areas I would like to concentrate on, and the first one relates to renal insufficiency and see whether these drugs are pretty good in that, and the second one that I want to look into is absolutely the effect on blood pressure, and both of them are somehow linked with cardiovascular and renal outcomes. So if we look at the studies from the SGLT2 inhibitors, I'm not going to go into details of that, but the renal kind of endpoints were first highlighted in the EMPA-REG study, and later both the CANVAS and the DECLARE TIMI studies, they also showed benefit in renal outcomes. And this led to the Credence study, which specifically looked into the renal outcomes. And as your patient had microalbuminuria and renal insufficiency, I thought it was very relevant to look into these studies. The Credence trial was a very interesting trial because it looked at patients who had an EGFR of between 30 and 90. But the intent there was that you should keep around 60% of the population between an EGFR of 30 to 60. And the drug met all outcomes, trial stopped early, and what they found that the primary outcomes had almost a 30% reduction, but the decline in EGFR was also pretty good at 31%. Now, this study led to a change in license, whereas SGLT2 were now licensed for an EGFR of up to 30. So I think that was a very important study. And more recently, and only published kind of last month, is the DAPA-CKD trial. I think most of us now know. And this is another SGLT2, which is now specifically looking at renal outcomes. And if we go to the next slide, we will see that here they've included patients with EGFR as less than like 25. And here the outcomes, again, were pretty much renal focused. But most important thing in this trial was that this had patients who had diabetes, but also patients who did not have diabetes. And they wanted to see if the benefit is extended to patients who do not have diabetes. So the trial met its endpoint, stopped early again, 39% relative risk reduction in primary composite endpoints, which were predominantly renal. But if I dissect it out and look at the renal outcomes just like that, there was actually a 44% reduction. But more importantly, almost a 31% reduction in overall mortality. And this was really very significant. So what I have seen here is that, the 5 trials consistently show benefit, that these drugs not only help with the renal outcomes, but they also help with overall mortality. So I'll be very keen to try this medication in your patient. The next, very briefly, on the blood pressure, again, this is just one slide I've just taken from the American Heart Journal, but what I'm trying to point out here that most of the studies of these agents have consistently shown a beneficial effect on the blood pressure. Recently, I reviewed a meta-analysis where they have really 27 randomly controlled trials, and they've consistently shown a benefit across. Now, how they reduce blood pressure is kind of not fully understood, but what we know is that the effect may be a combination of like osmotic diuresis, natriuresis, weight loss, and maybe effects on the nitric oxide and endothelial function and arterial stiffness. Not only will help with the renal and cardiovascular outcomes, so will have a beneficial effect on mean systolic and diastolic blood pressure. Thank you.
Thank you, Safdar. And again, I think you've addressed both the issues which are related to our patient. And it's not only the one patient. If we look back and look at most of the cases that we're seeing on a daily basis, these are the things that we're seeing. And again, thank you very much for elaborating on the blood pressure as well as the renal protection and the microalbuminuria part of it. Now I fly over back to our Safis region, and welcome Dr. Shahjada Selim for joining us. And again, I would like to ask the same question, same case, and making his life a little bit more difficult. Now that we've talked about the hyperglycemia and the microalbuminuria, the hyperuricemia, and the possible renal insufficiency which might be helping, do you, Shahzada, do you think any other benefit that this patient could get by starting this medication, knowing the history that I've shown? Over to you.
Yeah, am I audible?
Yes, you are.
Yeah, thank you, Dr. Abbas, for the kind introduction, and I am very much happy to be the part of the renowned experts of this region. And the topic is very much pertinent, and I am very much delighted to the way we are presenting the case today. Probably this will also encourage the other organizations or conference to have some insight to the details of a drug in managing diabetes mellitus. Now coming to my point and focusing this patient, Ms. Malik, the diabetes mellitus, we all know the most prominent metabolic disorders, and it is very much associated with the fatty liver disease. So I am coming to the non-alcoholic fatty liver disease and improvement with the drugs. Because the at least 62 to 69% of the patients with type 2 diabetes mellitus are having non-alcoholic fatty liver disease, and the most prominent parameters of measuring this one is ALT. This is the marker of inflammation. This is the marker of the fibrosis and the renal hepatic dysfunction. So experimental studies show that in addition to sustained anti-hyperglycemic effects by SGLT2 inhibitor, they can also improve the hepatic function status by reducing the ALT. But what we are seeing in the real world study, this study has been done in among the patients in Japan, and they found that the ALT reduction, back slide please. The ALT reduction among the patients with the empagliflozin user, it was very much significant, though the AST and GTT was not significantly reduced. But if we come to the next slide, Dr. Abbas, we can see that the a reduction of this ALT is very much statistically significant, and this is around 4% reduction of ALT comparison with using empagliflozin with the other non-drug placebo group. So we can strongly assume that this will improve the condition of the patient. Now, if we go for the next slide, Dr. Abbas, we can see that at the conclusion that when the patient is being treated with SGLT2 inhibitor along with a good glycemic control, patient may have improved hepatic function, and that can be documented by reduced ALT among patients with type 2 diabetes mellitus and FLD, and we can then assume that the patient will better quality of life and reduce the rate of chronic complication of diabetes mellitus. Thank you, Dr. Abbas.
Thank you, Shahjada Selim. It's actually very encouraging to see some of the data on the fatty liver disease, and as you presented, there was a whole session on fatty liver disease and diabetes effect on the liver. And what you've summarized is there is a potential medication which could affect the fatty liver disease as well, which actually there is none at this time to improve the significant fibrosis once this has happened. So again, something encouraging and something very relevant to this patient as well. Now, I will make everyone's life a little bit more difficult each step. So Hamid, over to you. Again, now you have to find any reason that you might be able to help this person. This is the same person we've already discussed about most of the thing. You were able to start with hyperglycemia. We talked about microalbuminuria, hyperuricemia, renal insufficiency, and fatty liver disease. Over to you, Hamid. And can you find any other good reason to start SGLT2 in this individual?
Yes, as you said, Abbas, you're making our lives a little bit more difficult, but what this agent has done is made our lives a little bit easier in terms of heart failure. So if you look at it, Dr. Naqvi has just spoken to us and told us about lowering the blood pressure, but in addition to that, what this agent does is that it acts on this feature of type 2 diabetes that we have now added on to the causes that lead to the pathophysiology of diabetes, and one of them is the chronic activation of the sympathetic nervous system. And it manifests its effect. The sympathetic nervous system manifests its effect through the kidney. So, and the receptors there are our friends, the SGLT2 receptors. So they in turn do the job of what sympathetic nervous system is asking them to do. And once we are able to block those, then the elevated heart rate in type 2 diabetes comes down. But as you can see, Abbas, that there is, obviously we don't know for 100% sure, but these are certain proposed mechanisms. We do know that when we have the SGLT2 inhibitors, and if you look at the top part of our slide here, you will see that both as the hyperinsulinemia and hyperleptinemia goes down, we have a decreased sympathetic outflow to the heart. There is a decrease in volume overload, the stress on the walls of the heart, as well as a decrease in fibrosis over a long time. Similarly, as you go down, as the sympathetic outflow to the blood vessels goes down, there is a better compliance in terms of the reactivity. There is also in the kidney, there is a decrease in sympathetic outflow again. There is correction in fluid retention. There is a decrease in the nephrolysin activity. So there is an increase in the natriuretic peptides. And there is a decrease in the activity of the renin-angiotensin system. So basically, it is not just very simply the fact that all these things that you saw, but in addition to that, as it is very clearly illustrated here, that the hearts of the people who have diabetes that is untreated, their energy levels and basic, the coin, the currency is ATP. So here, in the hearts of the untreated diabetics, the ATP levels are down. And as you can see in the lower panel, there is a decrease in glucose oxidation, ketone oxidation, so on and so forth. But once they get treated with, for example, an SGLT2 inhibitor such as empagliflozin, what you will see is an increase in the ATP levels by various mechanisms. So the cardiac energy, the ATP production is going up. And how does that help us? Abbas, is basically what we saw in the EMPA-REG trial. And that is where you can see here that there are 4 panels here. And in terms of panel A, what we see is this the effect on MACE, which is cardiovascular mortality, non-fatal MI, non-fatal stroke, or unstable angina hospitalization, compared to placebo, 12.8 versus 14.3. When you look at panel B, which is death from cardiovascular causes, what we see is 3.7% as compared to 5.9% in the placebo. Panel C, death from any cause, we see that the all-cause mortality, 5.7 versus 8.3%. So finally, when you look at the last panel, which is hospitalization for heart failure, which is our key component here, we can see it is nearly halved, 2.7 versus 4.1%. And the graphs clearly show you that this divergence occurs very earlier on in the course of the disease. So basically, what we are saying here is that SGLT2 inhibitors, in particular, the empagliflozin, for which we have this data, clearly has a very positive impact in patients who have heart failure in addition to their diabetes as a part of it. So
thank you very much, Hamid. And you put it in the best of words that anyone could put it. It's making everyone's life difficult, keeping up with all the information which is coming up, but it makes our patient's life easier in treating in this. So again, now, instead of making everyone's life difficult, let me pose a question to Dina and say, how would you suggest, we've talked about, we've seen the results of this laboratory findings, we've seen the case reports, we've talked about all the benefits effect of this patient in the current scenario. Dina, may I ask you, do you see any reason in which you can make this person's life easier in years to come, as far as preventing other complications than the cardiovascular disease or the deranged function test? So Dina, do you see any other benefit of it in years to come, even if this patient does not have that disorder or might not have the problem?
I mean, I think, I hope you can hear me, that
Yes, we can.
the only thing I would say is that maybe atrial fibrillation, that would be one thing that, because we know that atrial fibrillation leads to increased risk of congestive heart failure, and that is leading to further CV bad outcomes. So we know that through trials that it does help in patients. And actually, what is the good thing is that like empagliflozin works better for patients with heart failure, and then they benefit, right? And patients who have AF, they have worse outcomes in heart failure. And actually, when they did these studies, they realized that if you use EMPA, it consistently decreased the CV events with patients with atrial fibrillation. And not only that, they actually fared better.
So if you look
if you
at the,
going to use,
go ahead.
EMPA for a patient with AF better is another add-on. We want to use EMPA because we know that they benefit much more than just heart failure patients.
Thank you, Dina. So again, so you bring in a very interesting point as well, that even if this person does not have atrial fibrillation, we know for a fact that the patient with diabetes have a high incidence of cardiac condition, including the atrial fibrillation. And using a medication like this not only will prevent these cardiovascular risk factors, but also might help in this patient not developing the atrial fibrillation over the course of years. Again, just taking this conversation all along, again, Safdar, again, now being familiar with this case and have been repeated again and again, we've discussed all the good factors. Is there any other interesting fact that you can bring into our in the limelight to help people understand the mechanism of action or the uses of this SGLT2 in this individual? Over to you, Safdar.
Thank you. So I hope I'm loud and clear. So yes, of course. I think one area that is gaining a lot of interest and momentum is, and going on from what Hamid was saying earlier, is looking at the cardiovascular benefits and outcomes, is an area which involves heart failure with preserved ejection fraction. And I think this may be new to a few colleagues, so I thought I will just try and make it very simple as to what it is. So we're all aware of heart failure with reduced ejection fraction, which is defined as less than 40%. But if I make it very simple, so heart failure with reduced ejection fraction is where the heart doesn't squeeze very well. So there is a contractile dysfunction. It can't eject the blood very well. But the heart failure with preserved ejection fraction is where the heart doesn't relax very well. And therefore, you have an increase in pressure in the chambers. So what we also know, patients with diabetes have almost a 2 to 5-fold increased risk of heart failure. And if you look at any cohort with heart failure, you'll find almost 40 or 50% of these patients have diabetes. So quite a high risk. And the other problem is that the heart failure with preserved ejection fraction is not very easy to pick up. The good thing is the European Society last year actually defined it very well, which I put in this slide. And in these patients, not only that they have signs and symptoms, and the symptoms are really quite vague and not very specific, could be tiredness, shortness of breath, but ankle edema, such as in your patient, do point to these towards a diagnosis that need to be looked into. So in addition to signs, symptoms, and ejection fraction, you need some other markers as well. So either you have an additional criterion, which is the brain natriuretic peptide levels are high, or which is the one we do is the NT-proBNP now. The other thing is evidence of structural heart disease, which suggests that you have some problem related to relaxation, either with chamber enlargement or increased pressure. So what is very important, which is relevant to your patient, if you go to the next slide, you'll see that those patients who have microalbuminuria or have a reduction in EGFR have a higher incidence of incident heart failure. So these are the people that we need to focus on, because here we're going to find a lot of these ones. Now, The evidence for this is, a little bit indirect at the moment, but there are two very specific studies which are looking at actually patients with heart failure and preserved ejection fraction. The one is the DELIVER trial, which looks at dapagliflozin and its role in heart failure with preserved ejection fraction. And the other one is the EMPEROR PRESERVE, which looks at empagliflozin. And there are a couple of other trials as well. But these two are very important. And I think they're very important that if we identify that this is a huge problem in patients with diabetes, then this will have huge implications in terms of, how we treat these individuals, but will have very important economic consequences. So I think those are the most important things. There's one slide that I have put in, which is really the current guidance from the American College of Cardiology and American Heart Association, where they are recognizing this, that these drugs may have some role in primary prevention, particularly for heart failure. And we may see increasing use of these drugs once we have the results of these randomized control trials. Thanks.
Thank you very much, Safdar. Again, this is something which is a new emerging area of interest for the neurologists, because they got heart failure, but these individuals come up with a high pro-BNP and have a higher mortality. So again, that's something that you need to look at. So over to you, Mohammad. Again, a dear friend. Not to make your life much more worse, what do you think you can, and how you can help this individual, which we have all dissected and tried to help in whatever way we could? Is there still anything left that you can help her with or protect her from?
Thank you very much, Dr. Abbas. In the presence of a friend like Dr. Abbas, it is very easy to go ahead. Yes, there might be a problem which is not visible in this patient, and that is electrolyte disturbances in the form of especially hyperkalemia or hypokalemia, which is common in patients with diabetes. In a population-based study, the prevalence of hyperkalemia was 0.3% in the general population, but in diabetic, it was almost about 4%. Adding a SGLT2 inhibitor to the treatment of patients with diabetes may cause hypo or hypokalemia. The mechanism how the hyperkalemia is created, SGLT2 inhibitor causes osmotic diuresis, glycosuria, which causes a decrease in blood pressure. Decrease in blood pressure causes activation of the renin, angiotensin, aldosterone system, the final product of which, aldosterone, causes potassium to be lost. Loss of potassium, however, is not so prominent, but it also accompanies loss of magnesium. Decreasing blood glucose through SGLT2 inhibitor is counterbalanced by an improvement in glycemic control with an elevation of serum glucagon, reduction of insulin, which favors redistribution of potassium and magnesium in cells from the intracellular space. The net effect is a potential low increase of serum potassium and magnesium concentration. The next point, in a study in which dapagliflozin was evaluated its effect was evaluated on patients with diabetes. The effect of DAPA on serum potassium level in over 4,000 patients with type 2 diabetes mellitus across the DAPA clinical trial was explored. No clinically relevant mean change from baseline in serum potassium were noted in patients receiving dapagliflozin 10 mg or placebo, and few marked abnormality of serum potassium were reported in either group. All cases resolved without treatment and did not lead to discontinuation of therapy. We can see on the slide that the gray line stands for placebo, and the black line stands for DEPA. And there is only very few and limited changes from baseline in serum potassium level up to 24-week pooled population. The change for DEPA is almost 0.46 milliequivalent per liter, and for placebo it is 0.46, which is almost equal to each other. It means that DEPA doesn't increases potassium level more than placebo. And the distribution of marked abnormalities of serum potassium, that's potassium level more than 5.5 milliequivalent per liter for short time pooled data up to 24-week. Potassium level more than 0.55 milliequivalent per liter was the percentage was almost 8.6 in the DEPA group, but in placebo group it was 9.5, which is again comparable. Potassium more than 6 milliequivalent per liter was 3% in the placebo in the DEPA group, whereas it was 2.7 in the placebo group. Marked abnormalities of potassium in the DEPA group and in the placebo group were almost comparable. One of the abnormality which may be caused by adding SGLT2 inhibitor to diabetic patient is low serum potassium level or hypokalemia. And patients who are treated with SGLT2 inhibitor, hypokalemia may be a problem, but it's always or mostly it is asymptomatic, and mostly it doesn't require discontinuation of therapy. As we can see in these population-based study of patients who are receiving SGLT2 inhibitor, only 122 patients developed hypokalemia. Most of these patients were treated at the same time with the loop diuretic or with thiazide diuretic. It means that 95 patients of 122 were receiving a thiazide diuretic for the treatment of hypertension. That's why SGLT2 inhibitor alone does not cause significant hypokalemia. In conclusion, dapagliflozin is not associated with an increased risk of hyperkalemia or severe hypokalemia in patients with type 2 diabetes mellitus. Thank you very much. Over to you, Dr. Abbas.
Thank you, Wali, for just emphasizing one of the problems that are seen but are ignored very easily in our patient population is the electrolyte abnormalities. And since I've been more aware of these abnormalities, especially someone who's taking a diuretic, I have noticed that I have found out more people with electrolyte imbalance, and I've been able to help more people. And that's something that we need to make sure that we at least monitor once in a while, especially in our older patient population. In my clinical experience, the older patient population tend to have these abnormalities more often than younger population. Something to think about when you're looking at the neuropathy, new development of mental changes in someone who's already on these medications. And again, it's very reassuring that the SGLT2 might not be contributing in worsening of either or. Thank you, Wali, very much. I'll try to summarize, but again, before I summarize, I will ask Shahjada Selim to have, do you have anything left in helping this person out? Since we have discussed the whole array of issues that could be helped from hyperglycemia to renal to kidney to heart, is there anything that you would want to talk about at this time to help this person over a long period of time?
Thank you, Dr. Abbas. I am again highlighting one of the most important area while treating patient with type 2 diabetes mellitus. As we know from the 9th edition of Diabetes Atlas that at least 90% of patients with type 2 diabetes mellitus may be overweight or obese. So we have to target reducing blood sugar. At the same time, we have to maintain good weight of the patient. So I like to consider the weight reduction of the patient with the same drug that will reduce blood sugar. The studies have found that theoretically, it is very much understandable that the SGLT2 inhibitor inhibits reabsorption of glucose from the kidney tubules and allows glucose to go out, and it may be 50 to 60 grams per day. So huge amount of glucose is going out. So there is easily understandable statement is that the weight will reduce. But what we can find from the study, there's the one study found that has compared with for about 6 to 7 months, and comparing with the glimepiride 1 to 4 milligram once a day and 25 milligram of empagliflozin, and found that the 4.9 kilogram of body weight reduction over this time. This is very much promising. Now we can come on other studies, Dr. Abbas, we can find that the reduction of the body weight in terms of the metabolic improvement we should also consider. So the total fat mass reduction is very much important. We can see that by other oral anti-hyperglycemic drugs, namely the most prominent one, glimepiride, again 1 to 4 milligram, that can reduce only 40% of the gained fat mass reduction. But with the empagliflozin 25 milligram once daily, we can reduce more than 85% of the fat mass reduction. This is not only the weight reduction, it will also have the positive impact on the metabolic environment of the patient per se. Now, Dr. Abbas, we can come for another study which will show that the we comparing with the placebo and the empagliflozin giving 10 milligrams once a day or 25 milligrams once a day, the reduction of the body weight is very much promising in comparison with the, along with the sitagliptin once a day. So not only with the placebo glimepiride, with the DPP-4 inhibitor, the a promising effect of weight reduction with the fat mass reduction and improvement of the metabolic environment of the patient can be done with the same drug along with the reducing blood sugar level of the patients.
Wonderful, Salim. And I think you've hit the nail in the head. Diabetes, obesity, metabesity, these are all terminologies which are being evaluated again and again. We can, I think, go on further as far as some of the effects of the SGLT2, and this was briefly touched earlier by Safdar, I think, earlier too, the effects on the metabolic, the systolic blood pressure and the heart rate, and their potential effect on the cardiovascular disease. And the reason we discussed all this, initially a drug, a medication which was thought to be a kidney drug to begin with, just causing the glycosuria, has turned out to be a medication which is affecting so many organs in so many ways. And I think that's something that we need to continue to evolve. So it's all good that we've been hearing, but obviously with every rose there's some thorn or there's some issues that are associated with it. And I'd like to now know if there were any concerns among the experts who would want to discuss any side effect, any potential adverse effect of these SGLT2 inhibitors, and if they were concerned. I will start with Dina, going over to Nepal. If she has found any concerns as far as the medication is concerned and as far as the SGLT2 use is concerned. Over to you, Dina. Is Dina still with us? Okay. So again, this was a discussion I was having with Dina in the beginning as well about what her experiencing has been. And again, her concern was basically to do with diabetic ketoacidosis. Unfortunately, this is one term which has which kept popping up in years previously, that that diabetic ketoacidosis was something which was seen in patients using SGLT2. The mechanism of action is not only sometimes complex, but sometimes it could be simplified in a way that people who have tendency towards getting ketoacidosis, if they use SGLT2, they are more prone to develop ketoacidosis if you start using SGLT2. And the best example that we've seen is in type 1. there are studies which have shown the higher incidence of diabetic ketoacidosis if SGLT2 was used in type 1. Because if you looked at the theoretical way of how it works, it should potentially work in type 1 as well. But one of the major concerns for SGLT2 use has been the diabetic ketoacidosis in patients who have type 1 diabetes. And it's not only seen in type 1, it is also seen in type 2 as well. And that's one thing that we have to be very careful when we're treating patients with diabetes and using SGLT2. So we have to be aware of potential ketoacidosis, hyperglycemic ketoacidosis, and there's also a condition called euglycemic ketoacidosis, in which the blood sugar might not go up as high as you would expect, but you can still develop the ketoacidosis in these individuals. So starting off with this, let me go over to Hamid and ask him if he thinks there was anything that we should be, again, be careful with or be aware of when we're treating patients with diabetes and ketoacidosis, or patients using SGLT2.
Thank you, Abbas. Other than DKA, the other thing that was out there in neon lights was amputations, as you might remember. Now, the thing about it is that this is a brand new class of medications, and therefore, what we know is what we learn from the trials, right? So when we had these two trials in particular that were reported in earlier years, which is 2015, the CANVAS and CANVAS-R trial, we saw that when compared to placebo, if you see on the screen in front of you, 2.8 for placebo and 5.9 for every 1,000 patients treated with CANA, for example, in this study, there was a risk of amputation. Another trial that was done, which is the CANVAS-R, you see 4.2 to 7.5. Now here, as you keep moving, Abbas, what we do see is, based on the data, FDA has to make a recommendation. And so in 2017, this came out from the FDA that based on the new data from the two large clinical trials, FDA has concluded that this particular medicine causes an increased risk of leg and foot amputations. Anybody could do that. You know, if you have that kind of data in front of you, you will put what is called a black box on this medicine. And therefore, this black box stayed Abbas for some time till in 2020, they looked at the data again that was accumulated between the 2015 and the 5 years, and there were 3 clinical trials, and in those 3 clinical trials, it was found that the risk of amputation was less than previously described. So now, again, based on solid data, they said, okay, we may not need these black box anymore, but certainly the warning is still there. And Abbas, as we can see, that now we don't have a black box, particularly with CANA. It just states that it may increase your risk of lower limb amputations, and then you need to look for certain things, such as, you know, a previous history of amputations, if the blood flow is low, or you have heart disease, anything to show us that the blood vessels are at risk. Maybe this may not be the medicine for you, particularly if you start developing some pain, tenderness, sores, ulcers, or what have you. So as we go forward, we can see here that very recently, and this is, I think, earlier in this year in August, there was a large multi-center observational study, and this time there was no association found between the use of an SGLT2 inhibitor and below knee amputations among patients with type 2 diabetes. So at this point, what I would like to say in a sentence is, be careful of using this class of medications in patients in whom you suspect peripheral arterial disease, but as such, the black box has gone away. Thank you.
Thank you, Hamid, for recommending a smart and safe use of SGLT2. Especially, honestly, I was thinking of bringing this issue, which you rightly pointed out, and you've gone through the history of where it started off from. It's not over till it's over. So it means that probably this is something that you need to be careful with and keep an eye on it till it's completely ruled out with the other SGLT2 as well. So, Shahjada Selim, over to you. Is there anything that you would want to discuss in this patient? We've talked about ketoacidosis, we've talked about amputation. Is there anything that you can think of that you might or might not be helpful for this patient?
Okay, thank you, Dr. Abbas and the learned experts from different countries. For every drug, there will be few effect and there will be some side effect or adversity. And the patient with diabetes, they are very much prone to develop several acute or chronic adverse conditions. Like for this, if we consider this lady, there is every possibility of recurrence, urinary tract infection, and the drugs, these SGLT2 inhibitors from their inception, there is very much concern from every corner that will it increase the chances of urinary tract infection or genitourinary tract infection. So I am coming to the data what we are actually found in different publications. The pooled data from about more than 12,000 patients, they found that in total urinary tract infection prevalence among the placebo group and among the patient who received empagliflozin 10 milligram or 20 milligram, 25 milligram, it is not different. It is almost similar. So we can assume that the patient with diabetes, if their diabetes blood sugar control is not satisfactory, there is increased chances of urinary tract infection that may be not maybe due to the empagliflozin, dapagliflozin or canagliflozin, like these sorts of drugs. So we are coming to other data. Another study found that the patient who were treated with the empagliflozin 10 milligram, 25 milligram, and who had the placebo in the control group, among those, the number of cases with UTI it was not different in any of the group. If we segregate the participant according to their gender, in the male and female, again, in a comparison with the placebo group, if you compare with the 10 milligram empagliflozin or 25 milligram empagliflozin, there is no at all the difference of occurrence of urinary tract infection in male and female. Another study we can cite that the Dr. Abbas, we can cite that the prevalence of the urinary tract infection in the different categories with the placebo control and again the empagliflozin and 10 and 25 milligram. If we consider the urinary tract infection, the prevalence rate again very much similar. The pyelonephritis, the very much similar, and urosepsis again very much similar. So there is no statistically very strong evidence that this group of drug will increase the chances of urinary tract infection. But again, the prescribing endocrinologist should be very much cautious that the patients are very much prone to develop urinary tract infection for their age, especially the postmenopausal lady and other elderly men who are having the prostatism. So they should be screened the patient if they are having the recurrence of urinary tract infection. We can clearly say that if there is 3 or more occasions of urinary tract infection before starting this SGLT2 inhibitor, the patient is likely to develop urinary tract infection in near future. So we should not prescribe the drug to those patients. In other patients, it is very much suitable to start empagliflozin or dapagliflozin or canagliflozin. Thank you, Dr. Abbas.
Thank you, Dr. Selim. It's actually it's very reassuring to see that not everyone needs to be worried about getting a urinary tract infection, but you very rightly pointed out that person who's already having recurrent infections is more likely to develop it later on, and again it might get into a complicated situation with resulting in hyperglycemia. I would like to ask the last question in the interest of the time. I think we're running short on time, and again I'm not going to let Safdar decide what he wants to tell, because I have a question that I need an answer. If an expert like Safdar can give us an answer. Whenever we start someone on SGLT2, I have seen, and that there is some data as well, there's a somewhat increase in the creatinine. And that kind of is contradictory to what we all say about SGLT2, that they are wonderful in preventing renal insufficiency. So, Safdar, let me ask you a question directly. That how would you relate this transient worsening of creatinine in someone you're starting SGLT2 for the beneficial effect of creatinine? Could you comment on that, Safdar?
Yeah, sure. No, this is a very important concern and question, right, which a lot of people have. And I think what is very important is to understand it very well. So what we have seen in across the studies, particularly when the EGFR goes down, is that there is an initial dip. Now, this could be in the trial, it's about 10% dip in the EGFR. Now, this is related to, I think, the renal hemodynamics that are being readjusted. So you have a state of hyperfiltration initially that is reduced. And as the intraglomerular pressure is reduced, you see a dip. Now, what is very reassuring that this dip is usually in the first 3 or 4 weeks, but by week 12, in most studies, the renal function tend to improve with improvement in EGFR. And what I showed earlier on was that we now have plenty of evidence that these drugs in the long run actually reduce the decline of EGFR. So as far as I'm concerned, one would expect an initial dip with improvement within 12 weeks, but in the long run, we have tremendous evidence now to show, particularly from the DAPA-CKD study, the EGFR in the long run actually does better. And you can see in these, the two diagrams that are here, one with canagliflozin and pagliflozin, that in all the studies that we've seen, there is an initial dip, but then it recovers, and it actually in the long run does better. So as far as I'm concerned, you may see this thing, but it should not really put you off and stop the medication, as the EGFR will improve once the renal hemodynamics are reset, and it is unlikely to be a safety concern.
Thank you very much, Safdar. And again, with this, I would like to conclude the whole session and thank not only colleagues but experts in their own region, Dr. Dina Shrestha, Dr. Hamid Farooqi, Dr. Mohammad Wali Neseri, Dr. Safdar Naqvi, and our friend Shahjada Selim for joining us and giving us an opportunity to discuss a case which is very relevant for this time and age. I will give the mic back to our host in Sri Lanka and have them please conclude the session. Thank you.
So thank you very much, Dr. Raza, for the excellent coordination of the program. And I would like to thank all the panelists as well for going through the drug from top to bottom, left to right, and looking at it from all angles. I think we have all got a very good idea about SGLT2 inhibitors, and the audience would be able to use it in the appropriate context. So thank you. I would like to now conclude the session. Thank you, everyone.